Good evening, everyone, and welcome to another Family Medicine Residency Virtual Showcase. If you do not know me, I am Scott Allen. I'm the CEO for the Family Medicine Education Consortium. And welcome tonight. We are going to hear about STI prevention from Allegheny Health Network. Dr. Wolf has joined us, and I'll turn it over to him in just a second. First, I just want to give a little bit of background about the FMEC for those who do not know it. We are a catalyst, convener, and incubator, and I like to think of our priorities as sort of three-pronged. One is that we work with medical schools and medical students to increase their interest in family medicine and hopefully have them choose it as a career option. To that end, we bring about 300 students to our annual meeting every year to meet with residency programs and learn about family medicine. We help family medicine residents while they're in training to give them scholarly opportunities, help them present, help them connect with each other and learn from each other. And we also help the faculty at those family medicine residency training programs do the same thing, come to our meeting, present their work, learn from each other, all that good stuff. We cover 14 states and the District of Columbia in the northeast corner of the US. There's about 60 medical schools and over 200 family medicine residency programs in those states. We do an annual meeting each fall. Our next one is coming up in very soon, October 13th through the 15th, 2023 in Providence, Rhode Island. So hopefully many of you are planning to attend. And if you're not, I will mention our next year's meeting in a moment. We have actually 93 family medicine residency programs coming to our meeting next month. We also do a series of awards. We do learning collaboratives around different topics and have lots of different ways you can get involved with us if you'd like to help support the work we do. So if you're coming next month, great, we'll see you there. It's a beautiful city. And if you're not able to come this year, then please plan on coming to the 2024 annual meeting, which is September 19th to the 21st in Philadelphia, Pennsylvania. So with that, I am going to turn it over to Dr. Wolf to talk about STI prevention and Allegheny Health Network.
Hello, my name is Dr. Wolf. I am by trade a family medicine specialist, but also I am considered an LGBTQIA specialist. I see mostly people that fit within that that group of folks, which includes HIV medicine, addiction medicine, trans medicine, and of course, gay and lesbian health. I am, my title at the Allegheny Health Network, I'm the Dean for the Leafham Clinical Campus. That's the Lake Erie College of Osteopathic Medicine. And I'm a professor, clinical professor there, and also a clinical professor at the Drexel University Department of Family, Community, and Preventative Medicine. I'm going to share my screen and we're going to go ahead and get started. If we could just wait, I may not see your, if you have a question, so if you could just wait for the questions till the end, that would be great. All right, let me go ahead and share my screen. All right, is everyone able to see that? Okay, so today I'm going to be talking about STI prevention. We're going to be talking about PrEP, which is pre-exposure prophylaxis, and also talk about DoxyPrEP, which is doxy post-exposure prophylaxis. My objectives are to define HIV pre-exposure prophylaxis, or PrEP, by understanding the evidence for efficacy and employment of the CDC clinical practice guidelines to determine patients' eligibility for PrEP. I'm going to just describe the risks and benefits of PrEP, and then finally define who, when, and how to use DoxyPrEP. So first, clinical scenario. There's a 22-year-old Afro-American who is new to the office. I need to move this out of the way. New to the office, who's presenting asking about PrEP after hearing from a friend that 1 in 8 people living with HIV in the US were unaware of their HIV status. After asking important sexual preference questions, he admits being sexually versatile with men and occasionally being a bottom without condoms after a night of drinking. Which of the following is most important to document before prescribing PrEP to prevent HIV infection? Number 1 would be an HIV negative status. Number 2, creatinine clearance greater than 40. Number 3, evidence of immunity to tuberculosis. Or 4, a completed series of hepatitis A and B virus vaccinations. And the answer for the clinical scenario is an HIV negative status. And then finally, one more clinical scenario. Which of the following individuals would be appropriate candidates for PrEP? Number 1, men who engage in condomless anal sex with men. 2, transgender women and gender diverse patients who engage in condomless sex with another partner. Number 3, patients with a history of multiple STIs. And number 4, polyamorous couples who are having sex with multiple men and women with inconsistent condom use. And the answer is all of them. A good fact to know is PrEP is used by fewer than 30% of the people who could benefit from it in the United States, and this is a reason why, given this presentation, and why it's important for you to know what PrEP is all about. 80% of new infections are transmitted by people who are not aware that they have HIV or are not receiving HIV care. If we look at that HIV epidemiology, about 32,000 new infections are found in the United States. This is a stat from 2021. And a majority of those infections are occurring in the southern states of the United States. In the Northeast and Midwest, we're around the 14%, which is low. And in our HIV prevention toolbox, there are many different ways to prevent HIV. The top left is basically preventing maternal transmission of care, transmitting to her baby. You want to do HIV testing and counseling, use PrEP, do blood supply screening, microbicides, clean syringes, STI treatment. In some countries, medical male circumcision, treatment and prevention of drug and alcohol abuse, education and behavior modification, treatment as prevention, which means basically for those who have HIV, if you can get them to an undetectable viral load, that means they cannot transmit the virus, and condom use. So what is PrEP? There are many different, there are 3 different types of PrEP. 2 are oral and 1 is injectable. The most common form of oral PrEP is emtricitabine and tenofovir disoproxil fumarate, or TDF. Together, that is the Truvada, previously, now generic, so it's generic Truvada. A newer generation of oral PrEP is Descovy, which is brand name. It's the same 2 drugs, except the tenofovir is reformulated and more efficient in getting into cells. So as you can see, you're using, compared to the 300 milligrams of the tenofovir of the generic Truvada, you only have to use 25 milligrams of it. So you have less of the side effects related to tenofovir, and we'll talk about that momentarily. And then finally, there's the injectable PrEP. I'm mentioning this just for completion. This would be a special subset of patients that can get cabotegravir 600 milligram injection every 2 months, though it doesn't require an every 2-month visit. So that's why I say it's probably only for a small set of patients, especially maybe people who don't remember to take pills or are traveling and don't like bringing medications with them. The brand name for that is called a Pretude. When people talk about PrEP, they always think about, well, what are the safety issues related to PrEP? Well, we boil this down to 2 things. One is renal, the effect on renal function. If a patient is going to have any kind of nephrotoxicity, it tends to develop late, and it's an insidious onset, so it's a slow increase over time. When we looked at a study, it was an IPrEP study. They saw that renal function toxicity was 2% in the treatment arm and 1% in the placebo arm, and it was non-significant. We tend to see this more often in HIV treatment when people are treated with this drug as a backbone to HIV treatment, plus using other medications like an integrase inhibitor. And then the Partners in PrEP study showed there was no difference over 24 months. So this is unlikely to be a major issue, though you should still continue to follow the renal function. And just like with when someone is diabetic, if her A1C remains stable over time, normally you're checking it every 3 months. But if you have a year of my A1C is 6 or 5, you could start spreading it out. You don't have to check it every 3 months because you have now seen stability. The Partners in PrEP study showed no difference, so that was important to just note. There's also the fact that tenofovir, especially in hepatitis B treatment, was well known for causing osteopenia and also in HIV treatment. But again, we're looking at this for PrEP, and there's questionable clinical significance about osteopenia in PrEP. We know that women are at higher risk for bone toxicity, but the rate of osteopenia and osteoporosis are higher in HIV positive patients, as I mentioned, with the renal function. So this is, again, probably more seen in HIV positive patients and not in people who are HIV negative using PrEP. And when they looked in the IPrEP study, the bone fracture rate were similar between the treatment and the placebo arm. So though PrEP can potentially cause renal dysfunction, I've actually never seen it and been prescribing PrEP for over 15 years. And then the bone mineral density, I do see this in people who are treated with HIV, but we don't check for this. And the average person who's on PrEP is usually on PrEP for about 18 to 24 months. Though that obviously can change depending on their clinical scenario. So why do we need to monitor patients on PrEP? The biggest thing is to enhance compliance. Adherence is a key to efficacy in using PrEP. You want to also counsel about high-risk behaviors when you're seeing patients with PrEP. You want to assess for possible adverse effects or toxicity, which is very limited, and we'll again talk about that briefly. And identify early HIV infections. Remember, PrEP is not sufficient itself to treat HIV infections, but it usually is the backbone of most HIV treatment. The CDC guidelines for PrEP use, you want to assess risk. This would be usually men who have sex with men, high-risk heterosexual patients, and IV drug users, though that IV drug users are a difficult population to maintain compliance with using PrEP. If someone has an HIV-positive sexual partner and they want an extra layer of protection, though not needed, you could certainly prescribe PrEP. Anybody that's had recent bacterial STIs would be an appropriate person for PrEP. A person that has a high number of sexual partners, people who are inconsistent or not using condoms at all would be appropriate for PrEP. Commercial sex workers, and then again, sharing injection equipment. So what do we do when people come in for PrEP? First and foremost, you need to do an HIV test before starting PrEP. You need an HIV negative test prior to prescribing. And usually what I tell people, I prescribe it and I just tell them, wait until you see your HIV negative result before you would start the PrEP. And you want to check their renal function. You also want to evaluate for other STIs. And that's very important. I say evaluate, meaning what is the risk? And when usually with my residents and medical students, I tell them to first ask about how many sexual partners they've had over the past 3 months. How many of those partners did they use condoms with? or what percentage. And you can't just say, are you using condoms? You have to say, do you use condoms 100%? If it's just one time that they don't use condoms, they still would be appropriate for PrEP because that's a risk for HIV. When you are assessing for STIs, you also need to check for them. Just a brief note, it is important to check. Chlamydia is usually asymptomatic in the throat and the rectum. So you can't go based on symptoms. You have to go on based on where people have had condomless sex. And that usually means that almost 100% of the time you're doing a pharyngeal swab for gonorrhea and chlamydia. And then you're assessing is someone a top in a MSM relationship, then you do urine. If someone's a bottom, then you would do a rectal swab and you would let them do their own rectal swab. And then the other important thing to do is ask about a history of syphilis. And there's an important reason why. Especially in the Afro-American community, for reasons we don't know why, people often will remain what's called serofast to syphilis. And what serofast to syphilis means is that they tend to carry antibodies for a much longer time. We also see this in people who are HIV positive. For that reason, you should ask someone if they've had a history of syphilis, because when you check, do a screening for syphilis, they may come back as indeterminate or positive because they have a low level of syphilis antibodies in their blood. At our network, we have two different ways of checking for syphilis. We have what's called a syphilis algorithm, which basically does that screening for antibodies, and then we have syphilis monitoring that creates a titer. If you know that someone has a history of syphilis and they come back positive, but they don't have a titer, or it's a very low, like 1 to 2 titer, it may be that they're serofast, and that's all it is. They don't actually have syphilis. And a way to understand if they do have syphilis is a 2 log increase, meaning if someone is serofast and they have a 1 to 2 titer when you do the RPR, a new case of syphilis would be someone who went from 1 to 2 to 1 to 4 to 1 to 8. So 1 to 8 would be a new infection. So again, very important to ask if someone has had syphilis in the past. You want to counsel about PrEP adverse effects, and we'll talk about that shortly. Test for pregnancy if appropriate. Do a hepatitis B assessment. So you should test for a hepatitis B surface and core antibody. That will tell you if they, A, if they've had an infection, and B, if they are immune to hepatitis B. And if someone is not immune to hepatitis B, they should be started on their immunization for hepatitis B. You want to discuss access issues, though that's less of an issue today now because generic Truvada is generic and most insurance cover. And then you prescribe PrEP for the next 90 days. I want to take a moment to just say you need to take time to take a sexual history. You want to know who people are having sex with. Is it men, women? Is it trans men or women, or gender diverse individuals? Is it multiple individuals? That's just very important to know how many people, because the higher amount of individuals someone is having sex with, the more likely they are to get an STI, and the more likely they are to not use condoms. And then you want to ask, how many times did you have vaginal or anal sex with neither you or your partner wore a condom? And then finally ask how many of your sexual partners were HIV positive or you didn't know their HIV status. You want to counsel the patient about side effects. And this is where it's, people have a little misconception about PrEP, that there may be a lot of side effects or really a lot of toxicities, and there's not. The number one side effect from PrEP, which we're talking about oral PrEP, which would be Truvada or Descovy, generic Truvada that is, or Descovy, is nausea. And this often, less often diarrhea, but this usually subsides within a month. Any person that I've ever seen that have had nausea, usually it's because they forgot to eat lunch or dinner and they had some nausea in the first month. But 100% of the time, it went away. And that's in 15 years of practice. And then you need to monitor the kidney function. So that kidney function needs to be checked at each visit when you do your HIV test. So it's an HIV test, basic metabolic panel, or a kidney function test every 3 months. And then again, you spread the kidney function tests out after you see stability. You want to talk about adherence. Studies show that this only works if you're taking it daily. There is also multiple studies that show that vacation PrEP or 2-1-1 PrEP works also. This is basically where you take 2 pills a day before sex, 1 pill the day of sex, and one pill a day after sex. And you can see that that's not ideal for most people because you can't necessarily predict when you're going to have sex. So we, generally speaking, just have people take it daily. But it does work equally as well if you wanted to do the vacation PrEP. It's just not FDA approved to do it that way. PrEP common side effects. There's about 2% people will discontinue side effects. I've never seen it happen, but that is what is reported in the literature. Side effects include nausea, vomiting, diarrhea, and headache. You want to counsel the patient. Remember, PrEP does not eliminate your risk of getting an HIV infection, though it makes it extremely unlikely, 99%, that you are not going to get an HIV infection. There is still a very small percent chance that you could. And in those people that have got HIV infections, it has been from people who have had a resistance to one of the 2 drugs, tenofovir or emtricitabine. You want to advocate for condom use when you're talking to a patient, and remind them that keeping appointments is essential to prevention. What you want to do every 3 months is do a PrEP assessment. You want to be able to identify an acute HIV infection, and the next slide we'll talk about that. You want to check an HIV antigen antibody test and renal function. You will evaluate for other STIs, gonorrhea, syphilis, and now many labs are doing mycoplasma genitalium from the urine. You want to counsel about PrEP adverse side effects and adherence. You want to ask about new medications that someone might be taking, though there's not many medications that will interact with PrEP. You want to do behavior risk reduction, assess for pregnancy intent, and test it if there's any concern, and then prescribe PrEP for the next 90 days. And this would, when I say prescribe PrEP for the next 90 days, you're going to do this every 3 months. Sometimes what I'll do is if someone is maybe there's special circumstance, maybe someone's in a serodiscordant relationship where someone's HIV positive and someone's HIV negative, and because they're someone who's HIV positive with a viral load, they cannot transmit the virus, and someone's taking PrEP just for that extra layer of caution, I usually spread them out to an every 6-month visit because the likelihood of them getting HIV is 0. Signs and symptoms of suggestions of a acute HIV infection. Well, the best predictor of an HIV infection is fever and rash. Those are the number 1 and 2 symptoms. And then I just put this for completeness sake what the symptoms of HIV are for your viewing pleasure. Reasons to discontinue PrEP: if you have a positive HIV result, if you have acute signs of HIV, if you have non-adherence, so someone's not taking PrEP the way they should be, if you find that they are getting renal impairment, or if there's a change in their life situation that lowers the risk of HIV, then you can stop PrEP. What are the practical barriers to PrEP? There really isn't much anymore. Most private insurances cover PrEP. Medicaid covers it. If someone's underinsured or uninsured, there are copay coupon cards. You could go to the drug maker Gilead for Descovy, and often they will pay for the drug with a $0 copay. Or if you make too much money, they will cut the cost down to a very low copay. The CDC guidelines on PrEP in women, you want to do this along with usual screening to assess and test for pregnancy every 3 months. It's considered a category B in pregnancy, so it's safe in pregnancy even if someone would get pregnant while on PrEP. It's likely safe in breastfeeding. There's no concerns there, and it does not interfere with any oral contraceptive pills. The CDC guidelines on PrEP in women. The big thing on this slide that I need to mention is that when men start PrEP, they could do that 2-1 PrEP, 2-1-1 PrEP. They could do the regular daily PrEP. PrEP gets into the rectal tissue very, very quickly, so people get protection right away. There is an issue, however, with women or someone who has a vagina, that it usually takes about 21 days before it's therapeutic. So that vacation PrEP doesn't work in women. And what you need to do is advise women who are prescribed PrEP to make sure they're using condoms for the first month of PrEP before they would, if they want that, be sure not to get HIV. Next, I want to talk about DoxyPrEP, which is relatively new. It's been actually out for a few years now, but not a lot of people know about it. So I figured I'd talk a little bit about DoxyPrEP. What is DoxyPrEP? DoxyPrEP is doxycycline 100 milligrams, 2 tablets or 200 milligrams, 24 to 72 hours after exposure or after having condomless sex. It is important earlier you use it, the better. So if you use it right after, within that 24-hour period, you have the highest rate of reducing STIs. It is safe, well tolerated, and inexpensive. The side effects are limited. That include diarrhea about 5% of the time, abdominal pain about 2%, and vaginal candidiasis. There's some post-marketing stuff about liver transaminitis, but that is a very small amount. There is some resistance to gonorrhea. About 20% of U.S. isolates in the United States are resistant to gonorrhea. But the good thing is doxycycline is not used for first-line treatment for gonorrhea. There are 3 recent randomized controlled trials for DoxyPrEP that investigated DoxyPrEP efficacy to reduce bacterial STIs and the impact of intermittent doxycycline use on drug resistance in STIs and other bacteria. The first trial is called DoxyPrEP. And in DoxyPrEP, that was an open-label use of doxycycline 200 milligrams taken as PEP within 72 hours after condomless sexual contact. The inclusion criteria in this trial was male sex at birth, living with HIV or on PrEP, greater than or equal to 1 STI in the past 12 months, and condomless sex with greater than or equal to 1 male partner in the past 12 months. Sites included San Francisco and Seattle HIV and STI clinics. They had 390 HIV positive and 390 HIV negative participants. And the results were pretty remarkable. The risk reduction of an STI when people were on PrEP and not living with HIV, but just PrEP, was 66% for all bacterial STIs. In those living with HIV, it was 62%. If you put them all together, there's about a 65% reduction of bacterial STIs when you use DoxyPrEP within 24 to 72 hours after condomless sex or potential exposure to an STI. DoxyPrEP significantly reduces STI incidence in cis men who have sex with men and trans women who have sex with men. We know that now. The DoxyPrEP trial further kind of delineated that. And when we're looking just with people who are on PrEP, not people living with HIV, which is the right column. So there was a 55% reduction of gonorrhea, an 88% reduction of chlamydia, and an 87% reduction of syphilis, all from using DoxyPrEP. The numbers with people living with HIV were a little bit lower, but overall, these are really high numbers that were preventing STIs. There was another trial called the DoxyVac trial. This looked at men who had sex with men on PrEP for greater than 6 months, and they found an 85% reduction of chlamydia and syphilis, a 50% reduction of gonorrhea, and a smaller but significant reduction of Mycoplasma genitalium. And this is a relatively new STI. I shouldn't say it's not a relatively new. It's relatively recognized. We used to call it non-gonococcal urethritis, but a majority of those infections were actually Mycoplasma genitalium, which doxycycline is used as part of a treatment for, but is not exclusively the treatment. You do it's called a doxy-moxy, so you have to do a week of doxycycline and a week of moxifloxacin. And then there's a DPEP-Kenya trial. Now this is where things went a little bit off wire, but I wanted to certainly explain it a little bit in case you heard of it. The DPEP-Kenya trial was an open-labeled, randomized controlled trial of DoxyPrEP versus standard care, which is STI screening and treatment and risk reduction counseling without using DoxyPrEP. It looked at 446 Kenyan women between the ages of 18 and 30 years of age, and they were followed for 12 months. And here's what the results were. There were no difference. That means it was very, very strange. We have 2 other trials that are showing a great amount of great amount of relative reduction of these 3 STIs, and this one showed no difference between if you were taking DoxyPrEP or not. So then they started thinking, well, there has to be a reason for this. Is it compliance or is it biologic? So they did further analysis, and when they looked at the women's hair in the DoxyPrEP arm, they found that there were many women who had low or no doxycycline found in their hair samples. So what they ended up finding was women were saying they were taking the DoxyPrEP, but they weren't, and that's why there was no difference. They did look at the biologic potential cause, and they found that the penetration into vaginal tissue was no different than that of the anal tissue. So this is unlikely to be biologic driven. And then, so then we get to the San Francisco guidelines. So the San Francisco guidelines recommend DoxyPrEP to cis men and trans women. And trans women are patients who are assigned male at birth and have transitioned to female. They recommend if they have had a bacterial STI in the past year, they've reported condomless anal or oral sexual contact with one cis male or trans female partner in the past year, and especially if a patient has a history of syphilis, they should be prioritized. The San Francisco guidelines say that you should offer, not recommend, but they should offer DoxyPrEP using shared decision-making to cis men, and trans women who have reported having multiple cis male or trans female partners in the prior year, even if they have not had previously reported being diagnosed with an STI. And then finally, at this time, there's insufficient evidence to recommend DoxyPrEP for STI prevention for individuals who report having receptive vaginal sex. They are actually working on another trial to figure out to assure that this would work also in females, and it likely will. The CDC right now has not established guidelines yet, but currently they are evaluating and plan to make a statement about DoxyPrEP in the next few months. So with that, initial counseling with DoxyPrEP is you want to let the patient know DoxyPrEP has been shown to reduce the risk of STIs. It's not 100% though. So you still need to screen for STIs, and you need to treat for STIs. You got to remind a patient it doesn't protect from viral infections. So that means that obviously for a PrEP, then PrEP plus DoxyPrEP, you will prevent HIV, but DoxyPrEP alone does not prevent HIV, doesn't prevent herpes, monkeypox, or HPV. And then you want to talk about the potential side effects, which are very limited. And that's it. So I wanted to open that up for first about questions related to the presentation. And then after that, I will open it up to any questions about the Allegheny Health Network or about the Allegheny Health Network's family medicine program.
Thank you, Dr. Wolf. I just want to point out we did have one question in the chat from Raphael. What about the drug interactions relating to PrEP use? And I think he may have to leave, so if we could maybe do that one first.
Yeah, that's not a problem. There really isn't any drug interaction. So I'm sure that like things like when you're treating for TB, you may be you may need to look for drug interactions, but beyond that, there really isn't any, and anyone can be on PrEP. Other questions?
Hey, Dr. Wolf. Thank you for your presentation. So I was wondering, you had mentioned that a lot of the risk reduction is seen after like 24 hours or 48 hours after sex. And I was wondering if, like, to your knowledge, if PrEP and DoxyPrEP is offered at clinics if someone can't get into their primary care within that 48-hour window, or if they can go to urgent care and get it prescribed.
The unfortunate thing about DoxyPrEP is not a lot of people in the eastern part of the United States know about it. So if someone would go into a urgent care, then the urgent care clinic probably won't know about it. Generally speaking, what we do is we for people who are at high risk and you're using DoxyPrEP. Usually I provide somewhere between 15 to 20 doxycycline tablets, and with the instructions, take 200 milligrams orally within 24 to 72 hours after unprotected sex. So then they'll have a supply of it if needed. They are looking at, there's questions that come out from there. Well, what if someone's highly sexually active? What if they have sex on Monday and Tuesday? And, how do you go about doing that? And they're trying to answer those questions right now. So do you take it out, if you had sex on Monday and then have sex on Tuesday, do you take it on Monday or do you take it on Tuesday? The answer really is it should be taken soon after a potential exposure. And really it should, at the same time, it shouldn't be taken on a daily basis.
Thank you.
You're welcome. Other questions?
Hello,
Okay.
Dr.
Yes.
Hello, Dr. Allen and Dr. Wolf. Thank you so much for such a wonderful presentation. I wanted to ask, like, if the partner is HIV positive and is on treatment, should the person still take PrEP?
The honest answer is you don't need to, but for someone who's HIV negative and consistently having sex with someone who's HIV positive, sometimes that there's that small inkling of what if. You don't need to. So the answer is no, they don't need to be on PrEP. However, the reason why I say that there's a small percentage is every once in a while, maybe because HIV treatment these days, they're the integrase inhibitors. If someone takes any minerals with an integrase inhibitor, like magnesium, calcium, zinc, iron, If they take it with an integrase inhibitor, and I have had a patient, one patient who over the winter months decided he was going to take zinc with his HIV medicine to help prevent a cold. Well, what ended up, his viral load ended up going up to 500. Now, the likelihood of someone getting HIV with a viral load of 500 is relatively low, but in that circumstance, that offers a kind of a clinical picture where maybe an extra layer of protection would be good. But if someone's knows if they're HIV positive and they take their meds the way they're supposed to and avoids, these days, most regimens involve an integrase inhibitor. If they avoid minerals, then you shouldn't need it.
Thank you.
Any other questions about the presentation?
Hello, Dr. Wolf. My name is Rashawn Williams. I'm a medical student at PCOM. I'm actually currently at St. Vincent on a rotation. And I was just curious of if your LGBTQ health intersects at AHN and Monroeville intersects with Erie, how it is in Erie.
No. Well, here's what I should say. Yes and no. The residents who are at St. Vincent are able to rotate down with me, and actually, I had one of the residents at the St. Vincent program did that once a month each year, his first year, second year, and third year. He was a former chief at St. Vincent. So if a St. Vincent resident wanted to rotate down with me for a month and work in with me in my clinics, then they certainly could do that.
Perfect. Thank you so much.
And not a problem.
I had one other question, more relating to the actual presentation. Is there any risk of like hepatotoxicity with Truvada and PrEP? I feel like that. I don't know where I thought I read that. I thought that was a really big.
It's very common, actually. I hear from my residents a lot where they'll come in and say, because most of my residents almost all my residents prescribe PrEP. And they'll come in and say, well, I'm going to do an HIV test. And then they say, I'm going to check liver function tests and not kidney tests. And I don't know where that got out there, but it has nothing to do with your liver. Your liver will be completely fine. It's your kidneys that's the issue.
Well, thank you. I learned something. I thought it was liver toxicity too. Thank you.
Yep. Not a problem at all. And with that said, I'll open it up to if anybody had any questions about the Allegheny Health Network or about our family medicine program.
I was just wondering what type of exposure and training your residents get in LGBTQ plus medicine.
Well, because I'm an LGBTQIA specialist, all the residents rotate with me during their intern year. They rotate with me for a month. And then after that, we have an LGBTQIA track. And we currently have one resident in that track right now. He's an intern. And the way that works is that our residency have a longitudinal component with it. Your longitudinal component during your first 6 months is continuing orientation. So every Monday for the Monday afternoon, you have continuing orientation. And then when you flip over to the second half of your first year, and then throughout the second and third years, you have a half day per week to do whatever you want. That could be you want to become very proficient in dermatology, so you work with a dermatologist a half a day a week. That could be you want to learn how to run a private family medicine clinic, so you go to a private family physician's office a half day per week. If people are in the LGBTQIA track, what they do is for a half day a week, they for their entire residency, they rotate into my clinic. And then what ends up happening is then, because I don't accept, my clinic is full. So then what ends up is I divert all patients asking for me into their clinic. So then they not only see patients in their longitudinal, but then they also start seeing patients in their own clinic.
That's awesome. Yeah, thank you for answering that.
Yeah, not a problem. And I highly enjoy it. Highly enjoy the folks that are in the track and doing this. Any other questions?
I was
I
just
have a. Oh,
oh,
go ahead. My
sorry.
bad. Go ahead. No,
I
go
was
ahead.
just wondering how long the track's been going on for, like when that started.
We've been doing our tracks for some tracks have run somewhere between up to 8 years now. Like our sports medicine track has been going on for 8 years. Our LGBTQIA track, the official track, has been there, but not many people have utilized it. We're now on our second year with the second person in the track. I also, just as like an aside, what I do for the network is I take residents in with me. So the internal medicine residents will rotate with me when they want to learn more about LGBTQIA medicine or HIV medicine or even addiction medicine. So it's not just our family medicine residents that have that, but when we have someone in a track, that then usually eliminates other people coming into to the office because that person gets my full undivided attention.
Hi, I have another question.
Sure.
Does Allegheny have a strict cutoff on a year of graduation, or you're open to non-traditional candidates too?
We do have a strict as far as we don't go beyond 5 years. I for the most part, I think that if I look back over the last 5 years, everybody has graduated with it. There's nobody been in our residency that hasn't graduated within the year of the residency or a year of medical school.
Then I won't qualify. Anyways, okay, thank you.
You're welcome.
I just have a follow-up question about the areas of concentration and those tracks. Are you allowed to go through two of them, or is it just you can only pick one?
The way our longitudinals work is, I'll answer that in a two-part question. If you just designate a track, you head down that track. Now, with our longitudinals, the way the longitudinals work is you could change if you start down a longitudinal in dermatology and you decide you want to do something else, then 6 months later you could try something else. So you don't have to stay in that longitudinal the entire residency. The tracks tend to be permanent and only focused on one because there's so much involved in it. But just to make a distinguishing mark, a track and the longitudinal are two separate things, though you can create them, like enhance your education by doing both.
Okay, thank you. I was asking just because I'm interested in obstetrics, but I'm also interested in like LGBTQ care. So like the women's health track is very appealing, but I also don't want to, lose out on the opportunity to engage in LGBTQ care. But it sounds like residents can, still come rotate with your clinic and yeah.
Yeah, for you, I think what would be for you specifically, I would recommend doing the women and infant care track, and then do a longitudinal. You would do a longitudinal with me, and you could do the longitudinal. You could do it as long as you want. So if you want to say you did the OB track and you wanted to do a longitudinal with me for a year, and then do your longitudinal with an obstetrician or with a family-centered family physician. All the other time, you could do it that way too.
All right, thank you so much.
Yeah, not a problem. Any other questions? Well, if any of you do have questions outside of this that you would like to make more private, feel free to contact me. My email is Steve, that's STEVE, .wolfe, WOLFE, @ahn.org.